risks for toxicity, in particular weight gain, and cardiovascular or metabolic toxicity. Sorry, one sec. I'm getting some feedback that people can't hear me very well. Let's see if this helps. Please let me know if you can't hear me well. I can try to increase the volume. All right. What about now? No.
Sounds good.
Joe can hear me well. Are you sure you're not mute, Tim? Oh, okay. How is it now? Because I'm at max volume on my headset. Joe, do you hear me well? Yeah, I'm getting
Go for it.
Getting a lot of I can hear you, but then also I can't hear you very well.
How do I get this to?
Let me just take a quick look at my settings. Uh-huh. Yeah. I am on my headset.
Tim!
I'm just going to try unplugging.
Okay, Joe or someone, does anyone want to give me some feedback about whether you can hear me better now?
It's
That's
better.
A lot better.
Yeah.
It's better? Okay. All right. So I can't hear you guys very well, but it sounds like I'm getting a lot of feedback that you guys can hear me better. So we'll go with this. So when we think about regimen switch, we often are reacting in the clinic to situations like someone comes in and they say are having side effects from their medication, or they don't like the number of pills they're on. Oftentimes we're looking at patients who aren't suppressing and we're thinking of switching in those contexts. And I think we do a great job in that sort of reactive kind of an approach. But we don't do as good of a job about looking at people who are doing fine. They're suppressed on their current regimens. They have no issues. And asking ourselves whether this regimen may be causing problems that they can't feel that could become issues down the road, potentially in many cases 10, 20 years down the road. So my hope is that after doing this talk, that everyone will have a better sense for how to approach switch in patients who aren't having any issues. So specifically, what I'm hoping to accomplish is to help the providers and the clinic staff in general recognize when they have a patient that's on a TAF containing HAART regimen, so for example, Biktarvy, where they could potentially be on regimens that may have better long-term safety. And what that involves is deciding whether TAF or TDF or something that isn't TAF or TDF might be the ideal background regimen for the patient. And then looking at some of the relatively safer long-term treatment options that are underutilized, which include Delstrigo, Dovato, Juluca, Tivicay Truvada, or Cabenuva when we're trying to eliminate TAF from an HIV regimen. This is a slide that I presented earlier to the clinic back in 2020, but I wanted to start with this because it kind of illustrates where the problem that we have right now with Biktarvy sort of comes from. So these are recommendations from the International Antiviral Society, USA, IAS, and they put out guidelines every few years for HIV treatment in the US. Unlike the DHHS guidelines, which are hundreds of pages long, the IAS guidelines are typically 20 to 30 pages long, and they're designed to have a lot of reach. So there's something that you can read in a couple of hours and that are designed to help people make a decision about what they're going to do right now in a treatment-naive patient. So to some extent, they've focused on simplicity more than other HIV treatment guidelines. Now, if we go back to 2016, which you can see up here on the left, basically, the guidelines at that time involved quite a few different options. So we had boosted options like Genvoya, which contains cobicistat. We had regimens that used abacavir as the treatment background, like Triumeq. Regimens that use Descovy, so Tivicay Descovy, for example, is the background. And then even like a twice-a-day regimen with Icentris or raltegravir. When the IAS guidelines were developed in 2018, they made some really significant changes. In particular, they removed boosted regimens such as Genvoya from their recommended list. And we'll talk about that why, but essentially boosted regimens introduced more risks. They also went ahead and removed Icentris because it's a twice-a-day regimen from their list. And so what you were left with was something that is actually very, very straightforward. Essentially, what this boils down to in 2018 is patients should be started on either Biktarvy or Triumeq. And I, intentionally leave Tivicay Descovy out because, as many of you may know, Tivicay Descovy is essentially Biktarvy. They both contain a second-generation integrase in Biktarvy bictegravir and in Tivicay dolutegravir that are essentially identical, combined with Descovy. So although the IAS lists Tivicay Descovy or Biktarvy as options, the reality is that you wouldn't generally start someone on a 2-pill regimen like Tivicay Descovy when you could do the same thing essentially with a 1-pill regimen like Biktarvy. And so this really boils down to Biktarvy or Triumeq. And I'll just point out too that Triumeq as a drug can't be started without an HLA test, which takes 2 to 4 weeks to come back, and wouldn't be available for a new patient at the moment that they would see either the pharmacist here or the provider to start on therapy. So if we go back to 2018, what this basically clinically boiled down to for many clinics, including PACE, was start everyone that's new on Biktarvy. And that is what has happened at PACE. And has essentially been our practice since February of 2018 when Biktarvy was approved. So by now, 4 years, almost 4 years later, you will see that virtually every new patient in the clinic and more than 50% of our current patients in the clinic are on Biktarvy. So how does this change then with the IAS guidelines released in December of 2020? On the surface, this looks kind of similar. You have 3 regimen choices. Biktarvy is still there. Tivicay Descovy is still there. Notably, Triumeq has been replaced with Dovato, which is essentially Triumeq without the abacavir, which we'll talk about a lot today. But I think the most important change is actually quite subtle, and that's the addition of Truvada. This is a big change. This is actually a very big deal because what they're saying here is that you don't need to use TAF anymore as somehow better than TDF. You can really consider TAF or TDF. And this goes back to really taking therapy back to the way it was before 2016 even, when the majority of patients were on TDF-containing regimens. So today we're going to spend a lot of time talking about Tivicay Truvada as a potential treatment option. So, the holistically looking at the 2020 IAS guideline, they're really giving us 3 very different options: Biktarvy, Tivicay Truvada, or Dovato. And the reason these are different is that they differ in the nuke backbones that are being used. So you'll notice that in addition to the standard historical regimens, which are all 2 nukes plus something else, like Descovy plus Tivicay, or Descovy plus Bictegravir, or Truvada plus Tivicay, that they're also providing this option, which is somewhat nuke sparing, or just lamivudine, just 1 nuke plus dolutegravir. But in practice, I would say most people are still just prescribing Biktarvy and viewing that as sort of preferentially the ideal regimen, which isn't really the case. So why is that? And this is something that I presented before as well, but I want to rehash this because this is the fundamental reason why we would recommend at this point trying to use TAF sparingly. These are just quotes from guidelines. So IAS 2020, they say that among nukes, TAF is associated with greater weight gain than tenofovir DF, tenofovir disoproxyl fumarate, or abacavir. It's a very, very clear statement. DHHS, their guidelines were just released again in 2021 in the spring, and they have more to say about this now as more data has come about. They say using an INSTI-containing regimen, particularly Biktarvy or dolutegravir, has been associated with more weight gain than other drug classes, non-nukes or PIs. There's greater weight gain with TAF versus TDF, and that's been seen not only when you start with TAF versus TDF in a new patient, but also when you switch to TAF or TDF. So sorry, when you switch to TAF. So like if you take someone from say Truvada and you put them on Descovy, they gain weight, and that's been seen whether you're talking about HIV treatment or HIV prevention. And then finally, there's a genetic association between weight gain and HIV therapy. And we see essentially the greater genetic overlap someone has with Black women, especially Black women of South African descent, that they gain weight. So maybe not as much of a problem for young white men, but certainly a problem for African American and Black women. And even there's data on Latinas and on Latinos that suggests that their risks are greater than those of Caucasian men. I'm going to just review the data that kind of really shows this, the pivotal data that kind of illustrates this weight gain issue. That's the study done in South Africa over the last few years. It's still ongoing in Johannesburg, which is called the ADVANCE trial. They looked at about 1,000 people and they followed them prospectively. So of those 1,000 people, about 350 randomized to either Tivicay Descovy, Tivicay Truvada, or a tripla. A tripla is a non-nuke drug, efavirenz, combined with Truvada. So you have two arms that have Truvada, blue and green, and one arm in red that has Descovy. And it's a very relevant comparison because it's showing you the two standard of care options, Tivicay Descovy or Tivicay Truvada. It's highly relevant as well because Tivicay Descovy is essentially Biktarvy. So we can extrapolate this data to say Biktarvy versus Tivicay Truvada versus a non-nuke Truvada combo. And they have data out past what I'm going to show here, but they have more than 2 years of data on these patients. So we can really see what's happening over time. These are kind of a little bit complicated at first to look at, so I'll just kind of explain what we're looking at here. So on the bottom of these graphs, we have 3 charts. On the bottom of these charts, we can see time in weeks. So for example, if we look at this leftmost chart, we're looking at 0 weeks, 12 weeks, all the way out to 96 weeks or 2 years. And what we see on the y-axis is the percentage of patients who fall into one of these color categories. So we have 3 different arms in the study. There's Tivicay Descovy here on the left, and then there's our Truvada containing arms on the center and on the right. This is Tivicay Truvada in the middle. This is a tripla on the right. If you look at these graphs, what you'll see immediately is a lot of green on the right and the middle, the Truvada containing arms, not so much green on the left. So what this green tells us is essentially no or minimal change in weight. So for example, if you go to time point 0, when they start the study, they get their baseline weight done. If you look at the baseline weight at time point 0 on this left-hand graph, so Tivicay Descovy, patients who are on Tivicay Descovy at baseline, their weight obviously hasn't changed. It's still green. But as you follow them over time, we can see that by a year, only half of the people have no longer don't show a change in weight. The other half, something has changed in their weight significantly, greater than 10%. By 2 years, it's getting worse. So what we can see specifically is that almost 35% of them have gained 20% of their body weight after 2 years on therapy. So I weigh 160 pounds. You know, if I gained 35 pounds, like that it would be a lot of weight gain for me. You can imagine me being close to 200 pounds, like, you know, as Omar would say, that ain't cute. So, you know, this is weight gain that may or may not be reversible. I mean, you gain 35 pounds, it's not like you lose it overnight if you change your HIV therapy. It's going to take time to lose that, and it may also be associated with mobility issues, cardiovascular disease. Weight gain is a major problem. But you'll see that if you look at Tivicay Truvada or Atripla, we see some weight gain for sure, but it's not nearly as dramatic. I mean, we're looking at 2 years down the road, you know, 20 to 25% may have gained 10 to 20% of their weight. But the majority of people, their weight isn't changing, and it's really stabilizing around a year and kind of reaching a new sort of set point, which is consistent with HIV treatment in general. People get healthier when they're on treatment. They gain weight because of a return to health, and or just people tend to gain weight over time. So this is really what's unusual, is this consistent sort of unrelenting weight gain in women, and to some extent in men too, seen over years when they're on a TAF plus Tivicay or a second generation integrase regimen. Here is how we can sort of operationalize this. This is just an infographic sort of that I put together to show how weight gain varies with different HIV regimens. And the key point, let's just go back to this. The key point is that it's not necessarily the integrase inhibitor that's doing this. It's the switch from TDF to TAF that's most worrisome. Remember, the difference between this center graph and this left graph is just switching from TAF to TDF or using TDF in place of TAF. TAF is driving this weight gain to a somewhat lesser degree. Dolutegravir and Biktarvy are also causing weight gain. On the other hand, TDF is actually causing weight loss. When you give HIV negative people, like people on PrEP, TDF, they lose about a pound or two over a period of a year or two, which is, you know, opposed to what would happen if they did nothing, which is they typically would gain weight. So TDF actually helps with weight loss. And you see the same thing with older non-nukes like efavirenz and Viramunes, Atripla, nevirapine, Viramune XR, these older drugs. They, in some percentage of people, they actually cause weight loss, which may be due to toxicity and not a good thing. But nonetheless, there's that association. Everything else, if you just ignore TAF, dolutegravir, Biktarvy, TDF, everything else we're dealing with, PIs, first generation integrase inhibitors, most of the non-nukes, they're basically weight neutral, and we see changes in weight primarily due to other variables that correlate with being HIV positive, which is very much consistent with our experience of treating HIV over the last 30 years. I mean, we didn't worry about weight gain until this last few years. And it's been hard for clinicians, I think, to accept that weight gain may actually be driven by HIV therapy. Because of that, it just hasn't been an issue over 25, 30 years of HIV therapy. But it's really because of this shift in 2018 to TAF. That's why we're seeing this. And to a secondary extent, the use of these second-gen integrase inhibitors. So let's look at the same thing, but now thinking about regimens. So, you know, the TAF-containing regimens cause weight gain. Biktarvy, Tivicay Descovy, Genvoya, Sintuza. The TDF-containing regimens tend to be weight neutral or cause weight loss. Atripla, Delstrigo, which is TDF plus a non-nuke, and the newest non-nuke we have, Dorovirine, Tivicay Truvada. There's also, to some extent, like a sort of intermediate category, which are just TAF and TDF sparing. These are regimens that just don't have a second nuke. They don't have TAF, they don't have TDF, Dovato, Deluca, or Triumet, which contains abacavir. Those are sort of neutral. There's a association with weight gain, which generally seems to be because they're modern regimens that have been started in patients in the modern era when people tend to be getting fatter over time. We have obesity epidemics in most of the countries where these drugs are being studied. And people are returning to health because these regimens actually work. So, there are differences, in the clinical trial data, but I would argue that fundamentally, what we want to be doing is getting patients off of these TAF-containing regimens in red, and moving them onto these weight-neutral TDF or TAF-sparing regimens that are highlighted here in Delstrigo, Dovato, Juluca, and Tivicate Truvada. Not shown here is Cabenuva. Cabenuva would basically fall in here with Juluca. Cabenuva is essentially an injectable version of Juluca. So before we go into this switch stuff, I just want to see, are there any questions coming up from the audience about weight gain with TAF, the data around this, the recommendations for IAS to use TDF again? Does anyone have any concerns or anything that's not clear? Let me specifically ask just the physicians like Joe, Manoj. I'm gonna just actually, yeah, I don't know if I can mute everyone else. Let me see. I don't know how. Sorry, Fook. But Joe, Manoj, Seth, are there any questions that you guys have about this? Does this make sense? All right, I'm just gonna move on, but just if chat messages in are questions that come up, because now I'm gonna really start moving into what we can do about this problem, which is, I think often the reason why people don't switch is they're just not sure what it is that we can do to avoid TAF. Biktarvy is a very convenient treatment option. So the first part of this is who should we think about? Who are we really thinking about switching here? So as I mentioned at the very start of the presentation, we're not really so focused on what do we do about patients who are having problems. That I think we have a good solution there. So what I've listed here are a set of criteria that we can use, sort of like an inclusion criteria when we're thinking about switching our patients in the clinic. So the first thing is really looking for the low-hanging fruit. Patients who may be feeling fine on Biktarvy or another TAF-containing regimen, but are overweight and or have metabolic syndrome. And so they may feel fine, but we know that they're on a regimen that could be driving or at least contributing to that weight gain in some clinically relevant or even subclinically relevant way. So I would advocate for using a BMI cutoff of 30 right now. These are patients who clearly have a problem with weight that could put them at risk for cardiovascular disease later on in life. We're looking for people on TAF-containing regimens, specifically Biktarvy or Tivicate Descovy, but also we have patients on Odefsey or Simtuzo that could easily be on less toxic regimens. We want patients who are essentially uncomplicated, suppressed, adherent. They come to their visits. They're really not having any problems taking their medications. And this is why we use Biktarvy, is because most of our patients and many of our patients when they start aren't in that boat. We don't know whether they'll be adherent. And we don't know whether they're going to continue to succeed with therapy or whether they're going to struggle. But for patients who have been positive for years, are coming to all their visits, have viral loads less than 30 consistently for more than 6 months, I think we can really think about switching them. And 6 months is an arbitrary cutoff. Like if someone started therapy 3 months ago with Biktarvy and now they're undetectable for the last 3 months, I think we can think about switching those ones as well. Probably the most complexity comes with this question 5, or this point 5 here. We have to do a very good job of deciding whether these patients have any transmitted baseline resistance or acquired resistance. So have they failed regimens in the past? Do we not have genotypes at baseline, et cetera? Questions like that are really important. Biktarvy will work in a lot of patients that other regimens will not work in. And then lastly, we don't want to be switching people, what's our second to last, really don't want to be switching people when they're in a point of instability psychosocially. Like it's not a great idea to switch someone who's, say, just quit using methamphetamines or just finally like got into a boarding care or is struggling with, major life stressors. It's not worth destabilizing somebody at a moment when they don't have a lot of stability. And then this last point is just more technical, and this one's actually pretty easy to screen for. We just don't want to switch people when they're on Biktarvy because of drug interaction. So Bic is a very robust regimen. It can often overcome some of these problems, even though it's off-label in these settings. We really don't want to be switching people off Tivicay Descovy, for example, Tivicay Descovy or Biktarvy when they're on rifamycin or anti-epileptics that could lower exposure of HIV treatment. So what don't we want to use? You know, if we're just thinking about switching off Biktarvy, probably the second part that makes this confusing is not just who we should target, but what do we do? There's a lot of options. So to simplify this, I think across the board, I would just recommend, at least on this first initial sort of approach, is to just avoid the regimens that have drugs in them that can cause problems. So avoiding boosted regimens, regimens that contain Norvir or cobicistat. There's just no reason to expose people, generally speaking, to regimens that have drug interactions. Also, boosted regimens expose people to unnecessary medications. They have to be exposed to a booster, which can cause their lipids to go up, can cause cardiovascular issues, can cause GI intolerability. And it's not really clear that there'd be any need to do that. There's other options. So Genvoya, Stribild, PIs, we can really just ignore that, at least initially. I would argue that we should avoid TAF. If someone has a BMI over 30, there has to be a good reason to use TAF. You know, for example, we think they won't suppress unless they're on Biktarvy. Abacavir, it's not that abacavir is like a terrible drug, it's just that it's a big pill and it has a mild association with cardiovascular toxicity, and there's really no need to use it at this point. Efavirenz it's a perfectly fine regimen. It may in fact be the ideal regimen for many female patients, where efavirenz has a lot of data for excellent long-term safety. But switching to efavirenz is a risky proposition. It can cause a lot of neuropsychiatric effects, both in the short term and the long term. So people will get weird dreams, dizziness, like you might see people that just feel kind of stoned or out of it. And it can make people kind of turn people off towards HIV treatment. And if they don't adhere to it well, or especially if they stop it abruptly, say they lose their insurance, or they get into issues with immigration, you know, or they just have their meds stolen, whatever it may be, abrupt breaks in a triplet can lead to resistance, which is unique for that drug versus all other HIV drugs, and is a problem that leads to resistance, essentially. And then lastly, I agree with the IAS guidelines. We shouldn't be using twice-a-day regimens. It's just so much easier for a patient if the regimen is once a day. You can imagine, like, if you miss your dose in a once-a-day regimen, you can just take it anytime to make that up. But for the twice-a-day regimen, you're kind of on a clock, and after 6 hours or so, it's time for you're closer to your next dose than you were to the last, so you might as well just skip it. So it's hard to adhere to a twice-a-day regimen. So here are our options then. I've broken it down into sort of two general categories. We can evaluate people for whether they'd be a good candidate for TDF, and then we can use TDF-containing options, so Tivicay Truvada or Delstrigo. Delstrigo we'll talk about, but it's a non-nuke-based TDF-containing option. Or we could see whether, if they're not maybe a great candidate for TDF or TAF or abacavir, then maybe we could put them on a regimen that simply doesn't use any of those drugs, which we now have with drugs like Dovato or Juluca. The decision point here, and this can be a little bit complicated, but it's something that I would say most clinicians, especially clinicians that were treating HIV before 2018, have a lot of experience with. We used to use TDF pretty much in 75% of the patients in the clinic. So we know how to monitor and use TDF safely in pretty much any circumstance. TDF, when it's in a regimen that does not contain a booster, is much, much safer than it is when you give it with a boosted HIV regimen. So oftentimes our impression of TDF is driven by the use of TDF in boosted HIV regimens like Reataz, Norvir, Truvada, Darunavir, Norvir, Truvada. those regimens boost tenofovir as well and lead to higher risks for TDF toxicity. Regimens like Delstrigo or Tivicay Truvada typically will not lead to renal toxicity in patients who do not have baseline kidney problems. So the main problems, that TDF can produce are problems with the bones, problems with the kidneys. But as we've seen from PrEP and from HIV treatment, those are problems that are rare amongst patients who are not on boosted TDF regimens. That being said, if I would still avoid TDF in patients who have a very high risk for kidney disease. So like older patients with hypertension and diabetes, in particular, like women and African-American patients, although they have higher risk for weight gain with TAF, they also have a higher risk for kidney disease with TDF. So some of the patients that would benefit the most from stopping TAF also are not good patients for TDF. So it's not like we can just switch everyone to Tivicay Truvada, for example. And then just as a point to think about too, is that when you look at bone disease, this isn't something we have a good metric for screening every few months. This is something that really only gets checked when you do DEXA scans, which are, every 5 years after age of 50, or less. In some cases, it may be worth checking bone density scanning, which is a DEXA scan, earlier than 50 if we think that TDF may be the best regimen, just to make sure that we're not putting someone who has osteoporosis or osteopenia on TDF, which would not be a good choice for them, most likely. So if someone isn't a good candidate for TDF, that's really where one should start thinking about these TAF, TDF, and abacavir sparing options, Dovato and Juluca, which are 2-drug HIV options. They're dolutegravir plus something other than your typical 2 nukes. They're very easy to use regimens, but the big caveat with them is that you have to be sure they're going to work. Every single drug in the regimen needs to be fully active for these to work because you only have 2. Biktarvy, Tivicay Descovy, you can get away with some resistance because if 2 drugs must work, then of course the 3rd drug could be inactive and Biktarvy would still work. So just logically, if Biktarvy is Dovato plus tenofovir, which is what it is, and Dovato works, then of course Biktarvy will work even if the tenofovir is completely inactive. Or another way to look at it is Biktarvy will work even if the lamivudine or emtricitabine is completely inactive. That's just not the case with Dovato or Juluca. If any of those ingredients aren't active, it won't work. So that leads to a challenge. The other challenge is that regimens that don't have tenofovir in it will not treat hepatitis B. So we don't want to put people who have hepatitis B on a regimen that doesn't contain tenofovir. It won't work in the long run to treat their hepatitis. And that's easy enough to screen for, and we should know whether any of our patients are Hep B positive or not. These last 2 points, these other points, AIDS, adherence. Dovato and Juluca aren't great regimens for people who need sort of like every last drop from their HIV medications. If someone is hard to treat, maybe because they don't take their pills very regularly and or because they have advanced disease, we really want to be treating them with full, robust 3-drug regimens so that we're not taking any chance that they just need a little bit stronger therapy. It's not that you can't use Dovato in those settings or Juluca, it's just that you would really want to have a very good reason for not using Biktarvy or something more robust until their T cells recover. So if we've answered the first question, sort of who should we look at, what are the options to consider, the next kind of really critical question is their current HIV regimen, is Biktarvy or their TAF-containing regimen, is that actually causing weight gain? Remember that it's not like every person on Biktarvy gains weight. In particular, most Caucasian men that are on Biktarvy are not gaining weight from it. And in fact, there's very good rebuttals to the advanced data that have been developed and essentially manufactured, I would say, by drug companies like Gilead, as well as ViiV, right? The whole pharma industry is not happy with the thought that these newer big money-making drugs are causing weight gain. So there's a lot of data being generated to try to make a counter argument. And the counter argument largely goes that, well, when you look at people who, have been put on these drugs that are Caucasian, there really isn't much weight gain. So we want to actually have a way of checking that. And what I've found from talking to clinicians is that they actually don't have a great way, they don't necessarily know how to find the weights and to correlate those weight trends to see, is it actually like the weight is going up in response to switch to TAF or switch to integrase inhibitors. So let's see how we can do that. So I would use this diabetes detail flow sheet, which is seen here. So it's called diabetes detail. You go to flow sheets, review flow sheets. From that chart, from that view, there's a couple things that are nice. One is it can show you the weight from the beginning of when we have data in EPIC. So if you go to vitals or vitals details, which I think are more commonly used, they do not show your weight, the weight past like a year or two. And there's no way to scroll back further. So you just get like a few years of data. From here, once you click on weight, you can graph. And the graph is nice because you can then see sort of very broadly, like just looking at this, you know, what do I see? Their weight hasn't really changed. Going back over 10 years, this patient's weight has basically fluctuated around a mean of 200 pounds. So, I mean, you know, they're essentially not showing any changes in weight that correlate with anything. Their weight fluctuates based on whatever they're doing. And you can see that, like they start AAA here, the weight goes down, then it goes up. It's not, there's no evidence of an association with going from non-nuke to integrase in weight gain. Genvoya to Biktarvy, again, they go from TAF to TDF, they go from first generation integrase to second generation integrase, no change in weight. So someone like this, like I would say they don't have TAF associated weight gain. They don't have integrase associated weight gain. It still may benefit them to switch off TAF, but I would have a much lower threshold for saying this person shouldn't be on, say, TDF. In other words, taking them off Biktarvy to put them on something that can expose them to new risks like TDF, it doesn't make a lot of sense unless there's someone who has no risk factors for renal decline or bone density issues with TDF. They still may benefit from just taking the tenofovir out of their regimen and switching them to, say, Dovato. Dovato would be very appealing in a case like this because you basically take Biktarvy and just remove something from it. So again, if you don't need 3 drugs, why use 3 drugs? But let's look at the other scenario. This is what we're seeing a lot of. So this is a patient, you can see their weight trend over time is generally going up. We've seen some weight loss recently. We'll talk about that. But if you just go up to here, basically they've just gained weight proportionally over, you know, essentially 10 years with some fluctuation down and up, but largely just going up. And that's what we know, right? Like diets don't work. You lose weight a little bit, it goes right back up. You know, so there, and this is, especially if you have a med that's causing weight gain, diets will have no effect in the long run. So here, same thing, switch Genvoya to Biktarvy, but now you can see that after they switch from Genvoya to Biktarvy, the weight seems to go up and it kind of continues to go up. This was a female patient, BMI was like 40. When we switched them from Biktarvy to Delstrigo, this was about a year ago now, maybe longer even, we can really see the weight start to come back down, approximating something pre-Biktarvy with what you have with Genvoya. So this is TAF associated weight gain. TDF is helping with weight loss. And this is what you really want to look for. This is very important to do. The reality is that just looking at someone's weight isn't enough. You have to look at their weight and then make a decision about, is the weight going up in relation to HIV therapy? And if it is, can we show that it correlates with switch to TAF or switch to second generation integrase? If this kind of patient has mild risk factors for TDF associated problems, like you might use Dovato initially, but in the long run, you really want to be trying to get these patients onto TDF containing regimens because it will actually help them lose weight. It will spur weight loss, which can be the, you know, the spark that motivates someone to actually start losing weight, which is not easy to do. So this is, you know, a good response. You're not going to see that in all cases. I would argue that as long as you see a leveling off, that at least that's some benefit. You know, the continuous weight gain is what we're really worried about. So let's talk then about some of these options. I mean, so basically the key decision points are, is this person overweight on a TAF containing regimen and doing well enough that we could consider really getting them onto something that's not as strong? And then is the weight gain correlating with HIV treatment? If that's the case, if the answer is yes in both cases, then let's look at Delstrigo, let's look at Dovato, let's look at Juluca, let's even consider Cabenuva, or Tivicay Truvada. Let's look at some of these more modern non-Biktarvy options. So Delstrigo, you could paint a really nice picture for Delstrigo. I mean, it's not an IAS recommended first-line regimen for naive patients. It's not a DHHS recommended first-line regimen. Why is that? I mean, it's a great therapy on paper right here. It's once a day. It's just one pill once a day. It's got great long-term safety data. It's weight neutral at best, maybe weight negative. It doesn't cause short-term side effects. There's no real drug interactions that it causes. It's a one pill a day without food requirements. Very nice on the surface, but it's a non-nuke, and there's a reason why the IAS and the DHHS have stopped recommending non-nukes in first-line treatment. It doesn't work very well. People who have never been exposed to HIV therapy may have a 10 to 20% chance of being resistant to this, which is not good. So for example, you can't start someone on Delstrigo until you have a genotype back. If someone doesn't have a baseline genotype, it's risky to switch them to Delstrigo because they may have resistance to it, even though they've done everything right ever since they started taking HIV drugs. So switching to Delstrigo is a challenge. It's easier when we have the full history of baseline genotype. We know they have no resistance. But if you don't have all that data, I definitely recommend checking with me or Chia to see if we can make an educated guess. There's some clues, like, we can use prior history of success with non-nukes, but in general, unless you're sure that they have no resistance to the non-nukes, this isn't an option that you should consider without being 100% sure that they will suppress on it. And that's why it's not first line by the DHHS. And then the other issue is that it's a TDF containing regimen, so you have to be aware of that, and you have to monitor them for renal and bone issues and screen them appropriately before switching to make sure they're a good candidate for TDF. Tivicay Truvada is sort of the antidote to the problems of Delstrigo. It is a first-line regimen, and it's a first-line regimen because it has excellent safety and efficacy data in the short term. Essentially, the first-line regimens produce regimens that have a really good ratio of efficacy to short-term safety. It's like you want a regimen that will definitely work if someone takes it, won't develop resistance if someone doesn't take it, and isn't going to cause someone immediate problems in the short term that may discourage them from taking medications. But, it still has its challenges, like every HIV regimen, including Biktarvy. And the challenge here is that it has TDF and that it's a 2 pill a day. It's not a 1 pill once a day regimen. So I would argue that if we had Tivicay Truvada as a 1 pill once a day regimen, that we should have more people on that than Biktarvy. But because it's a 2 pill regimen, a lot of patients and a lot of providers don't want to use it. But to be honest, when you ask people, they generally don't care if they're on 2 pills once a day or 1 pill once a day, especially considering that a lot of people are on 5, 6, 7, 8 drugs, and it's irrelevant to them whether they take 2 or 1. Probably what I hear more from patients is they don't like big pills, and Truvada is a bigger pill. So it's just something to think about. But if you have a patient that you think would really benefit from TDF, is really gaining weight from TAF, and you're just not sure about their resistance profile, you can almost blindly switch people as long as they don't have bone or kidney issues to Tivicay Truvada. It'll work for anyone that Biktarvy works for. It'll work for anyone that Tivicay Descovy works for, and it will work for basically anyone that Simtuza works for, as long as they don't have substantial integrase resistance, which is exceedingly rare and only acquired. There's no baseline integrase resistance to worry about. So this is probably the most underutilized regimen we have here at PACE. And part of that is that it's not the perfect regimen for almost anybody, but it's a great regimen if we don't know what the perfect regimen is. And it's often something that we could use for patients who are on Biktarvy. So before I show just sort of a similar slides for Dovato and Juluca like this, I just want to show where these come from, because if you don't know, drugs like Dovato and Juluca are very unique. If you were to ask pretty much anyone that worked at Pace 5 years ago whether they thought you could give someone just dolutegravir plus one nuke, most people would have laughed at you or said that that is ridiculous and that nuke sparing regimens don't work. And that's because there were attempts to use nuke sparing or regimens that don't have two nukes over the years, since the early 2000s, and really beginning in the 2010s, that failed across the board. So darunavir plus Icentris didn't work. PIs plus just single nukes worked, but they didn't work very well. No one thought this would work, but it did, and it worked very well. And in fact, the data shows that dolutegravir plus lamivudine is non-inferior to dolutegravir plus Descovy or dolutegravir plus Truvada, both in starting. So a patient who's never been on HIV therapy, you put them either on Dovato or you put them on Tivicay Descovy, or switching. People are on, say, Tivicay Descovy or Genvoya or darunavir, ritonavir, Truvada, and you switch them to Dovato, which is this bottom study, Tango. Gemini and Tango. Gemini is naive, they've never been on therapy. Tango is switch. But in each case, the therapies work, which you can see here. This is the percentage of patients that are suppressed with viral loads less than 48, I think, or 50 they used at different time points. So this says, for example, that 90% of people in the orange group, which is Tivicay Truvada, versus essentially 86% of people in the Dovato arm, are undetectable 2 years into treatment. The people that aren't undetectable here are basically people, like you can see down here, that we just don't have data on them, that we don't know what happened to them. Probably they dropped out of care, moved on, etc. But what we can say is that when people actually take their meds and we can verify that they take their meds, that there's no failures. It's like 99.9% efficacy with both regimens. So they work, which is a big deal because it opens the door for regimens that only have two drugs. So Dovato is the most relevant because it's the one that has all this data. It's also the one that is the most similar to Biktarvy. So like if I have a patient that we start Dovato on, our message to them, hey Joe, how you doing there? We can all see your video. But we enjoy seeing your beautiful face. So Dovato is basically Biktarvy. When we switch someone from Biktarvy to Dovato, we'll often say, this is essentially the same regimen that you're on right now, but it's just one ingredient less. So you're, in a way, your body's already used to it. That's a very powerful message to people. It makes them essentially feel very comfortable switching. And so it's very easy to switch people from Biktarvy to Dovato. The other nice thing is about Dovato is that you don't need repeat safety labs because there's no new safety risks introduced. Switching from Bic to dolutegravir is not really much of a switch at all. Switching from emtricitabine to lamivudine is, again, not much of a switch at all. So we're just taking tenofovir away. The key point about Dovato, again, is resistance. You have to make sure the patient has full activity of lamivudine, which you can't assume they do have just because they're suppressed on Biktarvy. You need to review their history and make sure that they have not failed any regimens. What you can say confidently about Dovato is that for a patient who's never failed an HIV regimen, who basically started on therapy, became undetectable, and has since been undetectable, they do not have expected resistance to Dovato. In other words, people who've never been exposed to any HIV drugs have a less than 3% chance of having resistance to lamivudine at baseline. It's very, very, very low. The only times you really see resistance to lamivudine at baseline nowadays are patients who have been exposed to PrEP and have developed HIV while on PrEP, usually because they weren't adherent to PrEP. So be careful about that. And again, as I mentioned earlier, anything that you treat someone with that does not have tenofovir, i.e. Dovato or Juluca or Triumeq, they need to be screened to rule out hepatitis B. Juluca is identical in its concerns. It just the big differences are that we're using rilpivirine instead of lamivudine. Rilpivirine is not as simple a drug as lamivudine. It has its own unique problems. Additionally, it has the same problems that you see with Delstrigo. All of the non-nuke drugs, rilpivirine, dorovirine, efavirenz, nevirapine, you have to make sure the patient didn't have resistance to begin with, because they have a 10 to 20% chance of having resistance to this regimen. So we want to ensure that they have activity of rilpivirine. Those special points about rilpivirine are just listed here. Rilpivirine has to be taken with food. It can't be used with anything that blocks stomach acid. It requires a lot of help to get absorbed into the body. It needs stomach acid. When you eat, you make stomach acid, it helps dissolve the pill. You need that acid there to absorb this drug. Very simply though, if someone is a good candidate for Juluca, except they just happen to be on, say, like omeprazole, or they can't take the drug with food, you can just sub out the rilpivirine for dorovirine, which doesn't have those issues. So Piffeltro or dorovirine plus Juluca is a 2-pill once a day version of the same regimen that can be used to sort of obviate these issues. So we're getting towards the end. What I'm going to do is I'm not going to rehash the Cabenuva because we've just gone through that last time I spoke, and it doesn't really introduce any unique issues. But I do want to make sure we know how to monitor this. So if you switch somebody from Biktarvy to a new modern non-TAF containing regimen, the monitoring is going to heavily depend on one thing. Are they going to TDF or not? If you switch someone to TDF, you have to get, at some point early in that switch, labs to evaluate whether or not they're at risk for tenofovir toxicity, TDF toxicity. This is just the old school labs to rule out renal or bone issues from TDF. So we're looking at markers for risk for proximal tubulopathy. TDF will lead to challenges with absorption of electrolytes in the proximal tubule. And so you'll see wasting of electrolytes in the urine, which leads to low levels of phosphorus, for example, in the blood, high levels of phosphorus in the urine. We can quantify that as a fractional excretion of phosphorus. And years ago, prior to Biktarvy, prior to TAF being used, there was guidelines put out that look at how to monitor TDF and avoid TDF toxicity in patients who have kidney disease. So what it boils down to is just checking a baseline serum phos and serum creatinine, as well as urine phos and urine creatinine, so we can calculate the fractional excretion of phos pre-switch, and then again every 3 to 6 months while they're on a TDF containing regimen. In addition to that, we should consider repeating the DEXA or getting a first DEXA if they're close to 45 to 50 in age, or if we have otherwise suspicion for osteopenia for some reason. I would try to avoid TDF in a patient who has high risk for either osteoporosis or CKD. And we should monitor them for those problems as they stay on TDF over time. If though you're using a Dovato or a Juluca, which are regimens that avoid TDF and avoid TAF, the monitoring is relatively straightforward. There's no new safety concerns introduced. So all we really need to do in terms of monitoring is make sure that the drugs are still working. A very conservative approach, the most conservative approach I would recommend is this, which is to just check their viral load a month later, make sure they're still undetectable, check it again 3 months later, and then every 6 months after that. So, but it's not critical. And if you think the patient is fully adherent and they don't have any resistance, you could essentially just check labs whenever they're due for their next appointment. You want to counsel patients when you're switching off of 3 drug regimens to 2 drug regimens on the importance of adherence and also the importance of drug interactions. With Biktarvy, a lot of the drug interactions are clinically irrelevant when you're on Biktarvy because you have such a strong regimen. So you don't have to worry about drugs that lower the exposure of bictegravir 10, 20, 30%. It's just not going to make a big difference for a very adherent patient with good T cells. When you're on Dovato or Juluca, you do have to consider that. So like if they're on iron or calcium or especially magnesium, they need to space that from the integrase inhibitor from Dovato or Juluca. So, what I would recommend is switch to TDF, follow up closely on renal safety, switch to a TAF TDF sparing option, follow up on efficacy at 1 month, and ensure adherence and optimization of drug level. And that's really it for monitoring. I'm going to just skip this Cabenuva. I mean, just really quickly, Cabenuva is a once-a-month injection. You should only use it in patients who are right here, suppressed, no baseline resistance, have never failed a regimen, don't have Hep B. It's not an option for most people. It would be an option, though, for patients who are doing well in their therapy and have no resistance, no Hep B. And it's something that a lot of patients prefer. It's something also that guarantees you 100% adherence if someone adheres to all the shots. I would say that very few patients are 100% adherent to any oral regimen, but you can get there with this, and that may prove to be very valuable 20 years down the road. So just to recap, the key here is 1, look at your patient's BMIs. If your BMI is over 30, think about whether this is someone who would suppress on a wide range of options. If they're on a TAF-containing option, they have BMI over 30, and you think that they would probably do fine on basically anything, you should strongly consider trying to find a TAF-sparing option. The first step is to correlate their weight over time with their HIV regimens. Look for anything other than basically a zero trend. If there's any sort of evidence of a trend suggesting weight gain over time associated with regimen switches, you should consider switching them off TAF. And the best options from a not introducing new problems sort of standpoint are essentially TDF containing non-nuke or integrase options like Tivicay Truvada or Delstrigo, or TAF TDF sparing options like Dovato or Juluca. And then lastly, Cabenuva is an option, but it's something that you really have to make sure people are a good candidate for injections. So that is it. I think Foong will send out these slides. And if there's questions, feel free to email. If people have questions now, I'm happy to stay on. Any questions from the group?
Rajat, great talk. I really appreciate it. Really good work. I had 2 questions. Number 1 is, do we have any data that you know of on TAF and its weight effects in Asian or Asian American patient population? And then the second is regarding DEXA scans in patients, that you are on TDF or that you're proposing to change to TDF. I mean, we know there's a good CID paper about bone mineral density by Will Powderly, and it's a little bit dated, but what other data there is about doing that, earlier than 50 and how good that data is.
Yeah, so let me answer the first question first, because it's a little bit more straightforward. Essentially, there is some limited data on agents and TAF. It's not as robust, like you don't have anything like the ADVANCE trial or NOMSL, but we have essentially like investigator-driven retrospective look backs at changes with switch and or with initiation. They're obviously confounded by like the retrospective design, but you see essentially like when comparing them to similar studies where the only variable difference is ethnicity, you see essentially the same data as you do with Latinas or African Americans, a trend towards increased weight that seems to correlate with non-white ethnicity and female gender. I shouldn't say gender, female sex assigned at birth. So I would argue that probably it's the same. The other thing is that we already know that a lot of our Asian patients have a higher risk for metabolic disease independent of their weight because of the propensity to gain visceral fat. And so there is data that independent of weight gain, TAF also can cause increases in lipids. And I think that it's often boiled down to just, oh, they're stopping TDF. But when you really look through this data, I don't know that conclusion is like, I wouldn't say that it's concretely established. And I think there is also the possibility that TAF causes weight gain and metabolic toxicity independent of whatever is lost TDF. The second question is a little bit more complicated. I don't have as much. I haven't looked through the data in as detailed a way. What I can say is that, so I don't know, for example, whether there's like a study that looks prospectively at like doing DEXAs at an earlier age with TDF. But what I can say is that when you look at PrEP data, DEXA scans, and there's a lot of data on DEXA scans with TDF and like how they change over time with people on TDF. And it's a little bit worse than what you see with renal disease. So what we can say about renal disease is that patients with GFRs greater than 90 essentially don't show like a nominal correlation with progression to CKD or not when you look at TDF or non-TDF containing PrEP or TDF or non-TDF containing HAART over years. So we can say basically if someone has normal renal function, they don't progress to kidney disease on TDF, PrEP or not. With DEXAs, that doesn't seem to be the case. There is always some degree of subclinical TDF-associated bone toxicity on a population level that occurs. It's particularly bad for young men who have developing bones. So, you know, that like teenage group to like young 20s. Men over 28, 27, their bone density stabilized to some typically. And it's obviously going to be a problem for people who are older. I think in the older group is where I would advocate for just getting a baseline DEXA, because the DEXA approximates, you know, like it's hard to interpret a DEXA in this 20-year-old man, but it's not that hard to interpret a DEXA in a 40-year-old man. And even though it's an extrapolation and it is not validated for that age range, you can still use that data. But to do it, you know, I think where we have a really big gray area is like, what do you do about a 30-year-old guy that like, you know, may or may not have risk factors for osteoporosis, osteopenia over time? I don't know, and I think that it is an interesting question now because it may be of some value to get a DEXA 5-10 years down the road, you know, to find out. What I would say that we should at least do is check vitamin D levels and make sure that if someone's on TDF, that their vitamin D is normalized. But I think, as we know, vitamin D is not like a huge impact therapy. What we can say from PrEP data is that people who are vitamin D deficient on PrEP are more likely to progress to osteopenia if they also are on TDF versus those who are replete with vitamin. Yeah, the bone density is the bigger issue. And also bear in mind that TAF has a negative effect on bone density as well, although it's somewhat minimized. Did that answer for you, Joe? Sort of, was that enough info on those questions?
Yes, thank you.
All righty. Any other thoughts? Or otherwise, I'll let you all go. All righty. Well, thanks for taking the time to listen, and I hope that providers that are on the call that you'll think about switching some of your TAF-containing patients regimens to TDF or to TDF sparing or TAF sparing. All righty. Take care. Bye-bye.